This demonstration video describes two orthopedic fracture tables that are improving the performance of pelvic reconstruction and other orthopedic procedures around the world. The ProFX Pelvic Reconstruction Orthopedic Fracture Table provides the perfect table complement for any fracture procedure. The Hana Orthopedic Fracture Table optimizes THA, hip resurfacing, MIS knee, and many fracture protocols. Both the ProFX and Hana table systems are available from Mizuho OSI, bringing innovation to the table.
My name is Eddie Whalen. I'm an orthopedic surgeon from Savannah, Georgia, and today we're going to go through the various uses of the Mizuho OSI ProFX table as a surgical instrument. First, we're going to start with the prone position. We have arm boards that are variable that allow proper positioning for non-traction on the nerves. On the injured side, we have a lateral distractor, which was developed, as most of these parts were, with Dr. Joel Matta from Los Angeles. On this side is the well hip traction device, and this fixes the pelvis to the orthopedic table. This is the bent leg positioner to allow relaxation of the sciatic nerve. Can be used with a distal femoral pin. The feet are positioned in traction boots, which allow traction through the boot much more significant than with previous applications. The well leg is again in a traction position in the boot with a support under the thigh to prevent sag of the leg. The two spars are radiolucent, and they allow traction as well as flexion extension through a universal joint. This allows us again to pull traction to reduce the hip or reduce the hemipelvis. Again, the first application that I want to talk about is with a pelvic ring injury with a vertical translation, and that's what the pelvic fixation frame does for us. It allows us to fix the well leg and the well patient's pelvis to the table through shan screws and external fixation rods. That way, by pulling on the injured side, you can reduce the SI joint and the pelvic ring on the injured side while not spinning the patient on the table. In the acetabular application, the distal traction can be used to pull the femur down into position in the cephalad-caudad position, and then the lateral distractor can bring the hip ball out of the socket to allow reduction of the acetabulum. Again, the table with the radiolucency allows inlet-outlet views as well as the C-arm to move in for the Judet views of the pelvis to allow the position of the reduction. The other thing it can be brought up into the lateral position for application of a transsacral screw. Next, we're going to demonstrate the functions of the end of the spar. We're going to demonstrate that there is a control for rotation of the foot, again for reduction purposes. There is adjustment of the gross traction, which allows us to pull or push the leg into the appropriate position. And then there is a fine adjustment for traction, which allows us to make very small adjustments to the traction there at the end of the table. There is a device on this side of the table which allows us to do small amounts of flexion and extension through the spar, and then the large amounts of flexion, extension, and abduction, adduction are controlled through the crank at the end of the spar. Allows us to bring the leg out, leg in, extension, and flexion. The last feature here is called the constant track function, and it allows us to maintain constant traction on the leg to prevent nerve injury and changes of position of the leg without changing the amount of traction. Next, we're going to demonstrate the OSI ProFX table in the supine position for pelvic and acetabular fixation. Again, we can see that the patient is in the supine position. The adjustable arm boards with the temporpedic padding allow proper position without undue stress on the brachial plexus, as well as padding for the ulnar nerves. Moving down the table again, we see that there is a lateral traction device on the injured side. The well hip fixation device on the well leg side. Again, the traction device allows us to distract the femoral head out of the acetabulum for reduction purposes, and with pelvic injuries, Malgain type for vertical translation, the pelvic fixation device allows us to fix the well side pelvis to the table so that we can pull traction through the injured side without rotating the pelvis on the table. Again, this application allows first through the anterior approach we can place a transsacral screw for the vertical translation in the supine position, and if there is a symphysis diastasis we can go ahead in the same position and do the anterior approach to the symphysis for plating there. For the acetabular fracture, this allows us to pull distal traction through the spar and lateral traction through the lateral traction device to reduce the acetabulum for the ilioinguinal approach here. Moving down the legs, again, we see that both feet are in traction boots. These allow a very large amount of traction to be placed through the feet without injury to the foot and ankle. The spars allow us to internally and externally rotate the feet, which can aid in reduction of the acetabulum as well as the symphysis. Again, moving down the legs, we see that there are two types of traction. There is a gross traction, which allows us to pull traction to get close to the reduction and then adjust it further with our crank at the end of the table. Again, depending on the needs, the spar can be AB adducted, flexed, and extended. And again, with the constant track device, there's no undue traction placed on the leg with movement of the spar. This is the supine position for multiple procedures. What we see is we've manipulated the legs. Both, again, are in traction boots. The well leg is abducted and extended. The injured leg is extended and adducted. This allows us to pull traction to reduce the fracture, whether it's a femoral shaft fracture, intertrochanteric fracture, or even femoral neck fracture. It also allows us access to the greater trochanter for intramedullary nailing of the femur, the short nail for the intertrochanteric fracture, and you can use either the troch entry nail or the standard piriformis entry nail through this position. With the legs again in the traction boot and then positioning of the spar through whether it's adduction, extension, flexion, and then rotation, the fracture can be reduced prior to beginning the open procedure. This leg, this is the position where the well leg is extended, which allows us to place the patient in position without pulling the leg up into the flexed abducted position. I find that this works very well in the older patients that do have stiff hips, where it's difficult to put the patient up in a stirrup. This is a supine position for femoral or hip nailing using the well leg holder. One can see that the spar has been removed from the table on the well leg side. The well leg holder allows us to flex the hip and abduct the hip for exposure for the C-arm to evaluate the fracture reduction. The injured leg has been placed again in a traction boot. The femur is slightly adducted with the spar. There is a built-in abduction at the proximal spar which allows good offset, again, to give us good exposure to the greater trochanter for entry of the nail. Some people prefer this position, again, for the access to the femur and the X-ray position. This is the lateral position on the Pro FX. What we can see, again, at the head of the bed we have arm boards for appropriate padding. There is a bolster here to keep the torso in the vertical position. Coming down, we have a bar that holds the femur elevated. It's attached to the femoral elevator on the other side of the table. This allows us to raise and lower the bolster to help with our reduction. The well leg is again in the traction boot, and this allows us to bend it and hold it in good position on the padded bolster below. The fractured leg, again in the traction boot, allows us to flex the hip. We can lower the spar or raise the spar again to reduce our fracture in a closed position before we begin the open procedure. Distally, the controls on the spar allow gross traction to temporarily reduce the fracture, and then fine traction, which allows us to further reduce the fracture as well as over distract it for placement of the guide pin. This also allows us to release traction and actually compress the fracture at the time of the passing of the rod by reversing the traction. Also, there's rotation, again, to help us reduce the fracture and get the proper anatomic rotation. This is the Mizuho OSI Hana table. It was initially developed for hip and knee arthroplasty, but as addition to the anterior approach features of this table, it was also found it shared many of the features of the Pro FX for fracture work as well as the anterior approach total hip arthroplasty. This is the supine position. The patient is positioned with the arm across the chest, well padded on the bolster. The femoral elevator will be used, demonstrated in a few minutes, to elevate the femur to allow exposure in the anterior wound. With the anterior approach, the initial incision is made distal and lateral to the anterior superior iliac spine. The femur can be exposed through this, the femoral neck. With traction and external rotation, the hip can be dislocated and then the femoral neck amputated after the hip has been relocated. Once the femoral head is removed from the acetabulum can be prepared under direct vision. Additionally, C-arm is used to control the position, the flexion or the abduction and anteversion of the acetabular cup. The spar can also be rotated with slight distraction, and slight external rotation will usually give the better exposure to the acetabular preparation. Once the acetabulum has been implanted, again the position confirmed in abduction and anteversion with the C-arm, the femur is then extended, adducted, and externally rotated. What this does is bring the amputated femoral neck up into the wound. The femoral hook is then placed beneath the greater trochanter, and the motorized lift will elevate the femur and give you better exposure for the broaching of the femur. Once the soft tissues around the femoral neck are properly released, then the femoral neck will be elevated where there is an excellent exposure. Broaching of the femoral component is done under fluoroscopic control for control of size and position, and once the appropriate size has been implanted, the different femoral necks and heads are applied, and the hip is reduced by forward flexing the hip, internally rotating and reducing the hip. Once we're satisfied with the size and position of the components, the femur is again externally rotated, adducted, and extended to dislocate the hip and allow insertion of the permanent stem. And then once the stem is implanted, again the hip is brought into flexion, internally rotated with slight traction, and the hip is reduced. Stability can be checked by shucking the hip with traction, internally and externally rotating the hip, or even flexing and extending the hip. Once we're satisfied with the stability and the leg lengths being equal, then all that's left to do is close the fascia and the subcutaneous layer as well as the skin. In addition to anterior approach total hip arthroplasty, the abduction and traction functions of the Hana table make it an ideal table for hip arthroscopy. In addition to the traction components, one can also flex the hip for the arthroscopic femoral neck osteochondroplasty. Additionally, if an open approach is needed for the osteochondroplasty, again the position is ideal for this. Also, the fact that the spars are radiolucent allows good use of the C-arm to confirm position of your arthroscopy as well as any open procedures. The Hana table is also very useful as a fracture table. With the movable spars in a supine position, the patient can be combined for extension of the well leg and adduction and traction on the fractured leg. This gives us excellent exposure to the greater trochanter for either a trochanteric entry or a piriformis entry for an intertroch fracture or for a femoral shaft fracture. Additionally, it allows you to reduce and pin a femoral neck fracture, and indeed, if the femoral neck fracture is displaced in a younger patient, the anterior approach can be applied in addition to the fracture treatment for adequate reduction. The well leg holder on the opposite side can also be used rather than keeping it in the spar. In this application, the spar is removed and the well leg holder is applied to flex the hip and abduct the hip to remove it from position of the C-arm. This demonstrates the supine position for tibial nailing on the Hana table. By placing the lateral perineal post in the supine position, the injured tibia can be draped over the post. By ability to flex it, it allows an excellent entry point for the tibial nail. Another advantage of this application with the spar removed is if we have an open tibia, we can irrigate this very easily. No traction is necessary as the gravity and slight ankle traction will reduce the tibia. This allows also excellent access of the C-arm to confirm our reduction as well as application of any proximal or distal interlocks. Another application in this position would be the floating knee, where you had a femoral fracture as well as a tibial fracture. Once the tibia is stabilized, then through the same incision, a retrograde femoral nail can be applied, again using the C-arm to confirm the reduction. By raising and lowering the perineal post, traction can be applied to the femur with flexion and extension of the knee. If necessary, an external femoral distractor can be applied for reduction. This is the lateral application for the Hana fracture table. This shows using the lateral bolster attached to the Hana table, the patient is positioned in the lateral position. Both legs are fixed in the traction boots. The arm positioner holds the torso in appropriate position. This allows us to flex the hip and apply traction for reduction of femoral shaft fractures. This also allows excellent access to either a trochanteric entry or a standard piriformis entry femoral nail. Additional application is if one has a posterior wall acetabular fracture in addition to the femoral shaft fracture, the wall fracture can be fixed from the same position through extension of the initial incision.